Okay, we're going to talk a little bit about Chapter 40, Respiratory Dysfunction, and this is the pediatric portion, and we're just talking about upper respiratory, so it's only a certain amount of pages. Please see your course outline in order to know exactly what pages they are, and we will also use the maternal child book for this chapter. So we're going to start with acute streptococcal pharyngitis. The big one that we're going to talk about is Group A B hemolytic streptococcal infection. This is also on page 1200 in your textbook 40-3 where it does a comparison. So the onset is abrupt pharyngitis, headache, fever, abdominal pain, and strawberry-colored tongue. If this child has a fine sandpaper rash on the trunk, axilla, elbow, and groin, we're looking towards scarlet fever, which you really don't see a lot of scarlet fever anymore. There was at one time where that was quite popular. A lot of elderly patients may tell you in their history that they had scarlet fever as a child. Penicillin is given as far as treatment goes, and the child can return back to school after they have received 24 hours of an antibiotic. We don't want to force food on the children, but hydration is key. Typically in the pediatric population, they do become dehydrated very quickly. So we want to, make sure that we're trying to use maybe Pedialyte or watered down Gatorade, something that's going to help with electrolytes in between what they also their favorite drink. Stay away from sodas. It's going to be irritating to the throat anyway. Stay away from citrus. The other thing we need to talk about when we're just talking about upper respiratory infections in general, when we talk about pediatric population by age 5, they have less frequent respiratory infections because they do end up developing immunity. The diameter of their airways are smaller. They do have short and more open ischial tubes, so they're more prone to otitis media. On page 1196, 40-1 talks about signs and symptoms of a respiratory infection. Some of the things that we can consider as far as assessment goes is a respiratory rate between 50 and 60. We want to look at the rhythm and the depth, heart rate, O2 sat, temp, that is 38.3 Celsius or 101, cough that's been greater than 2 days, and an earache. Promotion, we want to do hand washing. They can take Tylenol and ibuprofen. This is for 6 months and older. And like I said, hydration is key. The other thing to consider in the pediatric population is otitis media. When we talk about otitis media, you can look at page 1205. And it's 40-3. Oh, I'm sorry, 40-6. That was pharyngitis. So 1205, 40-5, and 40-6. What this is going to go over is a couple of different things. It's going to look at terms on 40-5 and on 40-6 some signs and symptoms. So when I say the term to you, AOM, that's acute otitis media. That is typically the onset is ear pain, fever, yellow/red tympanic membrane on appearance. The other term that we need to talk about is OME. With OME, it's otitis media effusion. It's an inflammation and fluid, and typically without symptoms. And it may be, the symptoms may be rhinitis, cough, diarrhea. And typically the child will feel fullness in the ear, kind of like a swimming pool. Prevention, breastfeeding for the first 6 months, no propping the bottle up if the newborn or baby is drinking from a bottle. Immunizations, pneumonia, flu shot can be given at 6 months of age. Prevention or preventing smoke exposure and discontinuing the pacifier after 6 months. Nursing, our responsibility as the nurse is to relieve pain, facilitate drainage of the ear, prevent any complications that can occur, educating the family on prevention, and emotional support. Next, we're going to talk about the croup syndromes. They're on page 1208, 40-1. They affect the larynx, trachea, and bronchi. Typically, there's a low-grade fever, hoarseness, barking cough, and an inspiratory stridor. And I do want you guys to Google, just go to YouTube, Google child with inspiratory stridor or child with croup, and you're bound to get a YouTube video. It's really sad to see these YouTube videos of these poor little kids that are struggling with their breathing. But when you hear that stridor, it's very high-pitched and it's a distinctive sound. When we think stridor, it's an occlusion of the airway. We're not getting the full effect of being able to breathe in and out. The next one we're going to talk about is acute epiglottitis. It's a medical emergency. Typically, the child will have no spontaneous cough and will have drooling and agitation. Those are actually specific to the acute epiglottitis versus spasmodic. It's an obstructive inflammatory process. It typically happens between the ages of 2 and 5 years old. It's abrupt and they end up in respiratory distress. What will happen? They'll go to bed, no symptoms, wake up with a sore throat, painful swallowing, and a fever. They'll insist on sitting upright, typically a little bit forward with their mouth open. Their voice is thick, muffled, and frog-like croaking. They may have retractions. When these children come into the ER, you do not want to use a tongue depressor or take a throat culture because you will occlude the airway. They may require nasotracheal intubation or tracheotomy. Once they've received 24 hours of antibiotic therapy, the swelling will actually decrease and they're normal by day 3. Airway is always priority. They usually get steroids and they may have nebulizer treatments with epinephrine because what this does is it vasoconstricts and help decrease the edema that's going on in there, causing this obstruction.